But morning, everybody. Thank you so much for joining us. Like Sanjay said, first of all, we've been really pleased by the level of interest in this webinar, amazed actually by the amount of interest, and it's amazing to see so many people. I think there's 155 people already. So it's great to see so many people here. I'm Ollie, I'm one of the grants managers at the Dunhill Medical Trust, and I'd just like to quickly sort of introduce the rest of the team before we get going. So just across from me is Pedro, grants officer at the Trust. In the same building, but upstairs, is Sanjay, our head of research. And we've also got Sue, our chief executive, who I'll be passing over to shortly. And we're also really delighted to be joined by Katie and Fleur from Social Finance, who you'll be hearing from a bit more shortly. Just a few housekeeping bits and what to expect. So please do keep yourselves muted to sort of minimize any background noise. We are recording this webinar and we're going to be sharing the recording afterwards. So feel free to keep your cameras on or off as you wish. And for those who've given permission to have their details shared afterwards, we'll also circulate the attendee list in due course as well. Thank you so much to those of you who've given us questions in advance of the webinar. If you have other questions that come up during the webinar, please put these in the chat box. Obviously, given the number of people here today, it's going to be quite hard to manage it with sort of hands up. So if you put those in the chat box, we should have plenty of time at the end to do a sort of Q&A session. And finally, those of you who received the email ahead of the webinar will be aware that we're trying to have some time at the end for those of you who would like to potentially connect with other partners. So if that's something you're interested in, please do stay at the end and we'll be providing further details when we get there. So I think that's all from me for now. So I'd just like to pass over to Sue to introduce the call properly. And Sue, just let me know when you'd like me to move along with the slides.
Sure, yeah, if we can move along now, actually. Thanks, and the next one. So, good morning, everyone. As Ollie said, it's great to have you here today to talk about our latest call for proposals, this time on the topic of enabling older adults to remain independent. I'll share with you, first of all, that I am quite excited about this, but a little trepidatious, so excited and trepidatious in equal measure. We believe from what you've told us, our research, what we hear, what we read, that we're meeting an unmet need with this. We're attempting to bridge one of the so-called valleys of death with this call. It would have been quite easy for us to simply craft another call that would seed yet more ideas on how best to support older adults to live their lives longer on their terms. But what happens when the project ends? When it's evidenced it's a good idea, how do those who are in the position to adopt the service or intervention work out how to implement it at scale, be that locally, regionally, or nationally? So this call is looking for those who've already evidenced those great ideas and interventions and are looking for support to implement and scale up, but importantly as well, to do the implementation research. What are the barriers to adoption? Are there barriers in a different context? At what stage does it become economically viable? And what's needed to make it sustainable? Does it lend itself to an outcomes-based funding approach? We think there's a really rich seam of questions to be answered here, which would be very useful as our health and care services are now entering a new chapter in their governance, in their development, and in their evolution. So that's why I'm excited, but I'm also cautious because if this was easy, well, it wouldn't be needed, would it? So I'm just going to unpack a few more questions to kick us off and get us started. What do we mean by independence? Well, straightforwardly, the ability to make choices and to exercise control over your life. We don't mean just leaving people on their own to get on with it. We think this includes being able to live independently with or without a degree of support. What do we mean by service or intervention? Well, it could be a clinical intervention. It could be use of assistive technology, improved accessibility to advice, community support and guidance, continence support, support for unpaid carers, a whole range of things, actually. What evidence are we looking for? Could it be peer-reviewed published research, say, on a clinical intervention? Absolutely. Could it have been something that's been successfully piloted and has documented evidence of that, preferably carried out by a suitably qualified independent expert? And that could be a community-based service which has had an evaluation carried out by Social Value UK social return on investment methodology, or other robust version of this that's been carried out by suitably qualified researchers, say from the Social Care Institute for Excellence or from a university partner. And what do we mean by adopters? Well, that could be one of the integrated care systems or other health and care commissioners, local authorities, or a housing association, for example. But we also want you to have a research partner who can examine the conditions that need to exist for successful implementation and adoption. And we're particularly keen to support proposals that address needs in underserved communities, for example, coastal and rural communities, or improve the take-up and accessibility for a particularly underserved group in the population. One of the things that we thought might come up, and we're really not being prescriptive here, this is just an example, and it's an option that you might be pursuing or you might want to explore in more detail, are outcomes-based models of partnership with a commissioning body, in which case you might want to draw on the experience of social finance who we've got with us here today. And if you don't already have a relationship, we can put you in touch. As we said earlier, we've got Katie Saunders and Fleur Taylor-Sutton with us today. Katie's the Innovative Finance and Commercial Strategy Lead for Health and Social Care. She's building on her leadership of the Care and Wellbeing Fund and the Macmillan End of Life Care Fund, and is currently working with 6 integrated care board executive teams to develop community transformation funds. These multi-million-pound funds combine the expertise and energy of ICBs, national health charities, and place-based organisations to improve all-age population health. Fleur's the Associate Director in the Health and Social Care team at Social Finance and has supported the development of the Community Transformation Funds. She oversees the Dementia and Older People with Multiple Needs programme of work that we're also supporting, and is passionate about connecting service providers, funders and researchers to innovate, to shift the dial on outcomes that matter and build sustainability. So I want to hand you over now to Katie and Fleur. They're going to talk a little bit more about what they're doing and can be also on hand to assist us later with the Q&A. I want to underline, though, that this isn't the only model we're interested in, but we just thought that this might be something that you'd want to hear more about, because we know there are a number of commissioners out there who do have an interest. So without further ado, over to you, Katie.
Thanks, Sue, and morning, everyone. I wanted to start with just a couple of questions, and I'm going to scan through the pictures of you all on my screen. Please feel free to kind of wave a hand or nod a yes, or if you're feeling creative, maybe put something in the chat. So just interested, anyone here heard of social investment or outcomes-based funding? I've seen at least one wave now and a nod. Awesome. Yes. Thanks, Debbie, for using the chat. Great. Anyone used it? So people that have maybe heard of it, have you used it to drive transformation before? Okay, well, for those who haven't heard of it, hopefully this will be a useful intro. And for those that have heard of it, have used it, maybe some of your questions will help those to whom it's a bit of a newer concept for. Certainly when I joined Social Finance about 5 years ago now, I'd spent my career in the NHS. I hadn't heard of it at all. Increasingly, it is being used as one tool to drive sustainable transformation. Ollie, could you move us on, please? So essentially at Social Finance, we're a not-for-profit organisation, and we work with health and social care systems across the UK to really think about how to drive lasting change. We have deep partnerships and sector knowledge, and really that enables us to deliver this. Rather than me explain how this works, I just wanted to share a short clip from some of our partners. So Ollie, if you let me share now, that would be great. Thank you.
Yeah, you should be able to do your magic.
Awesome. I've confessed to everyone that this makes me nervous, so bear with me, and I'm hoping it will work.
I think what social finance means for me is really interesting, because it's it's a form of funding which supports evidence-based interventions to actually improve something, in this context healthcare, and actually make it, you know, more sustainable for the long term.
The momentum we're seeing now is really it's quite inspiring, actually. So currently we've supported in partnership over 4,000 people, and like I say, it's becoming this domino effect now. But most importantly, rather than thinking about exciting innovation, this is really genuinely impacting people when it matters most. So it's enabling those in their last 12 months of life to spend an extra 10 days in the place of their choice. So essentially rather than hospital. So really game-changing impact for people.
But the difference is we're really focusing on the outcomes rather than the activities that are being undertaken. So we're focusing on outcomes that are important to the person and to the system in which that service sits. So it's really driving and focusing on the outcomes that matter.
Really, this is a kind of a new and dynamic way for us to try and work in partnership to have impact for people living with cancer. It's about trying to do it's more than money, although when you hear investment, you think it's about money. It's about so much more than that for us. And it's really thinking about how can we achieve sustainable transformation together.
So far, the learning from the various engagement sessions with colleagues from social finance is meant that we're rethinking, you know, when it comes to other things we do, how do we come across as an organizations? What are the things we're measuring, and how we're really articulating and feeding that back into the wider system?
I think the bit that I'd emphasise is just the opportunity for co-creation. I think that's what's really exciting us is that opportunity to think really differently, and like, what additional support can we provide that goes beyond the money to actually set kind of partners up for longer term sustainable impact for, in our case, people living with cancer.
I think for voluntary sector organizations on there, you know, on the call, or who may be watching this afterwards, you know, especially with Macmillan and system partners taking the risk, then all the ask is to do things differently. You can still stay true to your mission, your vision, your values, and it's just working differently.
Thanks, Ollie, for letting me share. I'll let you get the slides back up. I hope that brings to life, or starts to bring to life, the approach and how we're working with partners. You heard there about our end of life care work, but as Sue said, we actually work across kind of population health, and we've been working with Dunhill and Alzheimer's most recently around how to improve outcomes for older people with complex needs, including dementia. Ollie, if you could move us on, please, that would be great. And I'm going to hand us over to Fleur, who's just going to bring the model to life in a bit more detail.
Thank you so much, Katie, and good morning, everyone. It's a pleasure to be here today. And as Katie said, I'm just going to try and bring the model to life a little bit with a few tangible examples before moving on to introduce you to our Roots to Scale framework as well. So just for a little bit of context, to date, Social Finance has launched 13 outcomes-based contracts in end-of-life care, as Katie mentioned, dementia and loneliness reduction as well. And we're currently using and leveraging this approach to improve outcomes in maternity care and place-based population health. It's a really valuable tool because it can be really used in a cross-cutting way across issue areas. And this work to date has really enabled us to develop a tried and tested approach to outcomes-based contracting. And working really closely and collaboratively with partners, this working model, if we just sort of move from left to right on the slide, allows us to identify what are the system stresses, what are those pressures that are getting in the way of a system being able to be innovative, and thinking about investment into prevention and community-based support. And then we think about fund investment, if that's appropriate, and examine those different requirements for success. What type of investment? Might it be repayable? Might it be blended finance? What type of investment might be needed to support the system to make sustainable change? And crucially, what types of service activities and interventions need to be and should be invested in to improve outcomes for people and systems? And for us, within the context of this model, moving from left to right, as we approach the outcomes, an economic value or sort of notional value is then assigned to a pre-agreed set of outcomes, and repayments are only made if those outcomes are achieved. And as you heard in the video, by linking the outcomes, or the repayments rather, to outcomes and not activity, social investments creates that really important breathing space for health systems to test innovation at low risk. And it offers an opportunity to mobilise and move sustainable transformation funding, and also address inequalities. Because social investment requires such robust system-wide partnerships, we're able to look at really working with our allies in the voluntary community sector, building community-based partnerships with organisations that have that knowledge, expertise, and those trusted relationships with communities, so that we can really deliver meaningful and innovative essential frontline services. And to bring this concept to life a little bit in terms of the work we've been doing over the last year, we've been doing some really exciting test and learn work in the dementia and older people with multiple needs space, supported by Dunhill Medical Trust and Alzheimer's Society. And we've been working with some incredible frontline organisations across the UK to test different models of delivery, innovative interventions that could potentially improve outcomes for people living with dementia and, crucially, their unpaid carers, as well as the broader system that seeks to support this cohort of people. And we've been working to identify and think through what type of investment might be needed to scale these essential services. And the work, without me going into too much detail, but if you'd like to find out more, please get in touch, I'll tell you more. But the work has focused on different aspects of the dementia experience. So we've looked and explored a range of interventions, including the use of care technology earlier in the dementia experience, different carer respite models, hospital discharge support, and pre-diagnosis support. And this sort of really broad approach to different aspects or parts of the dementia experience has enabled us to start building a suite, or rather a matrix, of outcomes that can be used to measure impact for individuals in the system. So to give you a flavour of that, we've been exploring carer wellbeing outcomes. What might we use to demonstrate and measure that impact? Looking at the implementation of the Zarit Burden Scale to assess and measure carer wellbeing and burden. We've looked at EQ5D5L, so a validated tool that can monitor changes to participant wellbeing. We've also developed more qualitative-based outcomes, which are really important, that look at acceptance and adherence to new technology, measuring attitudinal shifts and changes for people living with dementia and their unpaid carers. And we've been also able to look and conduct deep dive analyses on clinical data and individual patient cases to understand where an intervention has potentially diverted or delayed the need for hospital care. Ollie, can we move on to the next slide, please? So that was a little bit of a whistle-stop tour, but hopefully a little bit useful just to sort of bring some of what we're doing to life. And just to sort of follow on from that, segueing into how we do it, or one of the mechanisms. Taking an outcomes-based approach is something that we do at Social Finance, and we're really passionate and committed to, and we think it's a great way to build sustainability and scale. But of course, it requires strong, robust partnership working and a system-wide approach, which we understand at times can be challenging against a backdrop of austerity and competing priorities. So one of the tools and the ways that we help navigate and facilitate an outcomes-based approach and sort of mapping and thinking through how we might do that is by drawing on our Roots to Scale framework. So this is a framework that pulls together lessons and really deep learnings that have emerged from over a decade of work in this space. And it consolidates and brings together insights from those who have made progress towards or who have successfully achieved impact at scale. And just really quick, sort of overview or top level, what do we mean by scale? Well, I mean, for us, and there can be lots of different definitions, but for us, we think about scale as the end goal is lasting change for people in society. And part of achieving that lasting change is often some combination, although not linear, but so often a combination of services or practices expanding their reach, supporting more people, systems that embed change, sustainable change, and society and culture shifting their perspective. There is an attitudinal shift that's needed as well to drive scale and systems change. I'm just going to jump into my final slide there. So just in terms of how we do that. So the Roots to Scale framework helps us think through the foundations, the levers and the building blocks needed to affect impact at scale. We like to work with partners to identify that clear story. What are the outcomes we're trying to change? Who for and why? We explore different scenarios where social investment or blended finance could offer consistent funding. Map and convene partners to build a collective voice and really think through the levers that we can activate and pull so that we can reach more people, challenge the status quo and unlock capital as well. Can I pop to the next slide, please, Ollie? Thank you. So we're incredibly excited to be supporting Dunhill Medical Trust with this funding call, and we would be really happy to have a sort of further, more in-depth conversation with organisations that might think their proposal aligns with or could benefit from an outcomes-based approach. So if this is you and you'd like to find out more, please do get in touch via grants@dunhillmedical.org.uk, and the team will connect you with us at Social Finance. We look forward to hearing more from you and telling you more about what we do and how we could potentially work together. So thank you so much.
Excellent. Thank you so much, Fleur and Katie, and hopefully that gives all of you a bit of a sense of Social Finance's model and their approach to what they do. Like Sue said, it's not mandatory for this call to work with Social Finance, but it's one of the things that we're offering, and it might be a good fit for some of the interventions that you have in mind. So that was hopefully a nice, interesting section. This is probably going to be a less interesting section, me talking to you through the guidelines, but hopefully it's helpful nevertheless. Like I said, I'm effectively going to be walking you through the guidelines for the call, trying to highlight some of the key points and trying to address some of the questions that we've received in advance as well. I would just say, and I can't really stress this enough, the guidelines are available on our website. They have the full details of the funding call, so please do read them in full before you go on to sort of develop your ideas further, develop a proposal. But hopefully this gives you a bit of a taster of what we're looking for and some of the key criteria. So in terms of the interventions and the work that we're looking to support, I think something that's important to clarify right up front is that proposals can focus on a single intervention, or they could focus on more than one. But you will need to demonstrate how the intervention or the interventions can directly support older adults' independence. And like Sue said, we're really looking for interventions which are ready to be implemented and evaluated at greater scale. And I guess broadly with this funding call, we're looking to support proposals which could facilitate the longer term adoption of those interventions. And that could be in a variety of settings. As Sue said, we're not just limiting this to, for example, interventions which could be commissioned in the NHS. They could be adopted in community settings, by third sector organisations, local authorities, etc. But all of the work that's being proposed must be carried out in the UK. And with that in mind, as Sue said, we have to have at least one partner organisation who could adopt the intervention longer term involved in the bid. All of the proposals will need to align with our key principles for research, and those are outlined in our strategic framework, so give that a quick read if you're not familiar with it. So we're looking for patient care and public involvement and engagement, PPIE, and equity, diversity and inclusion in all aspects of the work. We're looking for a commitment to capacity building and career development, and we're looking for multidisciplinarity where that is appropriate. And I think given the kind of work that we're looking for in this call, that's probably going to be in most cases. And just to highlight, the guidelines do provide examples of some things that we're not considering eligible. So I thought it would be worth just making those clear now. So like Sue said, this call is not designed to support the development of new interventions or interventions that don't have an existing evidence base. We're not looking to support pharmacological treatments or interventions focused specifically on cancer patients. I know we've had a few questions around other specific patient populations of older people. So broadly, that's fine as long as the focus is on, as long as you can make the case that the intervention is focused on older people, then that would be eligible. We're not looking to support the sort of purchase or distribution or evaluation of standalone healthcare products, technologies, aids, etc., that aren't being delivered as part of a wider service or program. And finally, just to clarify that that the call is not designed to support postdoctoral fellowships or PhD studentships. So whilst you might have fellows, for example, involved in specific aspects of the work, the aim is not for these programs of work to be carried out in the form of a PhD studentship or a postdoctoral fellowship. In terms of who can apply, so the lead applicant needs to be based at a UK university or other eligible research organisation, and there's a link there to a full list on the UKOA website that includes things like NHS trusts and organisations. In some cases, we might consider a proposal with a local authority as the lead institution, and if that's the case, we would need to see evidence that that local authority has a suitable research infrastructure in place. So we'd probably be expecting good links with local universities, researchers, etc. And we welcome applications from first-time or early career researchers, but however, given the sort of complexity of the work involved, we would expect to see more experienced team members and quite clear plans for the support of the lead applicant. We can have multiple applications from the same institution, the only sort of caveat being that if we were to fund multiple applications from the same organisation, we'd obviously need assurance that they have the capacity to be involved in multiple applications. One important, and this is a slightly technical point, but I think it's important to raise now, is that if you are a lead applicant on a current grant from us, or you're a co-applicant on 2 or more grants from us at the moment, then you might not be eligible to apply, at least not as a lead applicant. So do get in touch with us if you think that might be you, or you're not sure, and we can look into that further. And then, like I said, there must be at least one adopter partner or organisation within the team, and it can be multiple, doesn't have to be limited to just one. So beyond those kind of stipulations around the lead applicant and the lead institution, we're trying to provide flexibility as to who else can be involved. So we really do encourage applications with co-applicants and collaborators, both from within and beyond academia. So that might be people with lived experience, it might be community partners, it might be health and social care organisations, it might be social finance, it might be industry partners. There's flexibility here, there's no restrictions as to the number of organisations that can be involved. You obviously just need to make the case for who's involved in the proposal and why they're the right fit, effectively. And international collaborators are also permitted where justified, but like I said, the work itself must be taking place within the UK. Okay, budget and costs is normally an important point for people. So I guess that the headline facts are that we've allocated £2.4 million to the call, and we might have some flexibility around that if we receive enough applications of suitably high quality. But applicants can apply for up to £1.2 million for a maximum duration of 4 years. So really, we're expecting to fund a relatively small number of quite large awards. We've said in the guidelines that we expect most proposals will probably cost at least £500,000, given the sort of the type of work that we're looking to support. And we do welcome applications that include part funding or in-kind support from other sources as well. In terms of eligible costs, I'm not going to go sort of blow by blow through these because there's a lot of detail in the guidelines. So I would advise sort of reading that section in full and coming to us if you have any questions. But I just wanted to pick out some key points So broadly, we'll cover the direct costs of the work for universities, so not overhead costs, and that's because host universities receive a contribution to the indirect costs of charity-funded research through the Charity Research Support Fund. However, if you have any community partners involved in the proposal, we do expect their contribution to the work to be included in the budget at their full economic cost. So that would include a contribution to their overhead costs. And broadly, we will cover the cost of materials, consumables, etc., to actually implement the interventions. We recognise that there is a cost, obviously, to implementing an intervention. If you can't implement it, then you can't then go on to evaluate it. So we will meet those costs. But like I said, there's a lot of detail in the guidelines. Please do read them. We know there will be questions. There'll probably be specific costs or cases that aren't quite clear or that we haven't covered. So have a read and please get in touch if you have any specific questions about eligible costs. Moving on, I guess, to the overall timeline and the application process. This is a sort of adapted version of the timeline and the guidelines, and I thought I'd just pick out a few key points here. So this is a two-stage funding call consisting of an expression of interest and then a full application stage. So the call is obviously now open, hence why we're all here today. The call opened officially last week, and the expression of interest stage ends on the 6th of September, so in 6 or 7 weeks' time. During this time, applicants must have an expression of interest conversation with us, and I'm going to focus in on those conversations a little bit more in just a moment. Anyone who's successful at the expression of interest stage will then be invited to submit a full application. So you'll be notified week commencing 9th of September, and you'll then have until sort of late October to submit a full application. That needs to be submitted via our online grants portal, but we do hope to make a template of the application form available ahead of the full stage opening. All those full applications will then be peer reviewed, and you'll then have a period in December where you'll have the chance to respond to key points of the peer reviewers' feedback. So do make a note of those dates, 9th to 13th of February, and make sure that you are available, because we won't really have any flexibility around those dates. Obviously, I think that's the last week of university term before Christmas, and we're certainly not going to be around here over the Christmas break, and we don't expect you to be around answering rebutting peer reviewers' feedback either. So after the Christmas break, the applications will be considered by the expert panel and our research grants committee. They will assess the applications and then come together in early February to consider all of the full applications. Given the sort of potential scale of the awards, we expect that most applications will also be subjected to an interview. So we've blocked out those 2 dates for those there, 26th and 27th of February 2025. So obviously, if you are successful and invited to the full stage, please do make sure that you're available on those dates. And then to wrap it all up, by late March, early April next year, which feels absolutely miles away, but it's going to fly by, I'm sure, all applicants at the full application stage will be notified of the outcome of their applications. I think we had a couple of questions around when we expect work to start. So we don't have a strict stipulation around this. We typically say that we expect grants to start within 12 months of the grant offer letter being sent out, although we can be flexible around that if there's a good reason for it. But there's no strict date when you're expected to start. And obviously, if there are any sort of conditions in the grant offer letter, then the work wouldn't be able to start before those have been met. So I think this is my final slide. So I just wanted to focus in on these expression of interest conversations, because this is sort of the stage that is of most relevance right now. Like I said, if you are putting together a proposal, then you must have an expression of interest conversation with our triage panel. So that comprises members of the staff team and, when available, members of our research grants committee before the end of 6th of September. To book in a conversation, you use this Calendly link, which I've put in the slides. We are going to share these slides afterwards, but there's also a link in the guidelines. So we have a number of pre-existing slots that you can book in for, sort of stretching from next week up until early September. Again, I do just want to stress that there's quite a generous number of slots there, but obviously once the slot has been taken by somebody, it then becomes unavailable. And we have quite limited capacity to have conversations outside of those times. So once you've read the guidelines, if you're pretty confident that you are going to go ahead and develop a proposal, I would advise that you book in for a conversation sooner rather than later, so that you don't miss out on the opportunity. So in terms of who needs to be involved in those conversations, obviously the lead applicant must be present, and we'd like at least one representative from each of those partners or organisations who could adopt the intervention longer term to also be involved. Obviously, it's a bit of a more the merrier case, but we know that once you start getting more and more people, it becomes hard to sort of coordinate diaries. So those are the people that have to be involved. And in terms of what we're expecting, so you'll be asked to provide a presentation, a maximum 20-minute presentation to start the conversation off, which focuses on these 4 points that I've highlighted here, and the guidelines go into a bit more detail as to what falls under each of those 4 categories. So we want you to tell us about the intervention, so what its components are, the existing evidence for its effectiveness, etc., the program of work that you're proposing, so your implementation plans, your evaluation plans, where it's taking place, your approach to PPIE and equity, diversity and inclusion, and tell us about the proposed team and their roles in the work. So that will take about 20 minutes, and there'll then be time for discussion, questions, a chance to dig into the proposal in a bit more detail. And we expect that these conversations will probably take about 45-50 minutes. So this is more than just an informal chat about your eligibility. We are looking for you to come with fairly robust plans for what you're looking to do and the work you intend to carry out. So hopefully that was helpful. That's a bit of a whistle-stop tour, like I said, of the guidelines. Please do read them in more detail before you go any further. But we've now got, I think, plenty of time, actually slightly more time than we had planned, which is great, to answer any questions that you have. I think the chat has probably been quite busy. I haven't been keeping an eye on it, but I'm going to pass over to Sanjay and Pedro to lead us on a bit of a Q&A session.
Thank you, Ollie, and thank you everyone for great presentations, and also those who provided questions when registering. And please do keep questions coming in the chat box as well. Pedro is going to be monitoring those and we'll be answering them in a bit. But I thought that we'll start with answering some questions that had been provided in advance of the webinar. So I thought maybe I'll tackle one first, because I can see quite a few people are asking related questions. So what are the best ways to share research and find potential partners to work with? So participants seeking partners can stay on the line after this question and answer session to connect directly. And also I can see people are already doing it. Please put your contact details and what you're looking for, what your expertise is in the Zoom chat, and we're going to save this and we will circulate this after the meeting. So rest assured that's I can see it. I can't even keep up with sort of reacting and putting hearts and thumbs ups to them. It's amazing seeing how people are already interacting with the chat. I guess we've got a few other questions. So I'll start with one for Katie and Fleur. Do applicants need to align with Social Finance's outline topics on their website in order to partner with them?
No, absolutely not. Don't be put off by our slightly not-for-profit website, which actually doesn't showcase everything we do. So no, we would be delighted to hear from anyone, and actually we work across many areas. The outcomes-based approach is a really flexible tool, and as we've said, we've spent the last year or so, working really closely with Dunhill and Alzheimer's Society, specifically looking at improving outcomes for older people with complex needs, including dementia.
Perfect. Thank you very much. No, that's great to hear. And so I might pass this next question to Ollie. Are we only interested in medical related interventions, or are community-based interventions also relevant?
Yeah, so like I said, we're not just interested in, I'm assuming by sort of medical based interventions, people are talking about clinical interventions. So like I said, no, we're interventions that could be adopted in the community, third sector, a variety of settings are eligible. We'd welcome that.
No, thank you very much. And yeah, I just think it's probably worth also emphasizing, although, you know, it's in the guidelines and you've mentioned it, can applicants apply for a service improvement or evaluation project?
Okay, yeah, so we have in the guidelines, I guess, a few examples of the sort of work that we would be looking to support. You know, this is not sort of an exhaustive list. I'm going to read it off of my piece of paper so that I've got like the exact wording. But some of the things that we've said we could support would be, you know, scaling up an intervention that's been trialled in a clinical setting to look at its real world effectiveness, implementing and evaluating an existing intervention in a new setting or a new region, and understanding the contextual factors that impact its wider implementation, adapting an existing intervention for a new setting or new population and looking at its effectiveness in that new context, or comparing and evaluating a variety of different implementation strategies. So I guess in terms of the question, you know, what we're not really looking to support is simply evaluating a service that already exists and has already been commissioned. Obviously, if this is about adapting an existing service, implementing it in a new setting, in a new context, and evaluating it in that new context, then that would likely be eligible. Hopefully that sort of hopefully that answers that question.
No, thank you. And then I guess it might be useful to understand what outcomes we're expecting. So Sue had touched on this earlier, to be measured in the call. So for example, how would you expect people to prove or evaluate if the project was successful? I think maybe I can, you know, provide, you know, further sort of context to that. So a key part is that proposals must generate evidence of, say, the economic impacts or the social impacts, or the challenges, or how they're being overcome, the implications or the sustainability of the intervention, essentially to facilitate its longer term adoption. So we expect that the approach being taken to generate this evidence or data will be developed in collaboration with the partners or organizations which aim to adopt the intervention following the end of the program. Beyond this, we do not stipulate any particular measures, especially as the interventions in question should already have robust evidence backing them up. I guess to spell out some more aspects of the, oh, I'm being asked to speak louder. Is this, yeah, okay, I will speak louder. The proposed, so how broad is the scope of independence as a requirement for the call? The proposal must describe how the interventions in question can directly support older adults' independence and reduce future health and social care requirements and/or costs. By independence, we mean the ability of older people to live life on their own terms and take part in activities which are meaningful to them. This can encompass a range of interventions that aim to enhance autonomy, mobility, and self-care, for example. This can be on health-related interventions, community-based and technological solutions as part of a service. And so I guess that leads on quite nicely to reiterating what an intervention means. These can be structured activities, services and/or programs aimed at addressing specific challenges or needs faced by older adults to support their independence. These interventions should be evidence-based, meaning they are supported by research indicating their effectiveness in achieving their desired outcomes. So I think we've actually covered most of the pre-submitted questions, and I'm really sorry if I was speaking a bit quiet. I'm in our shared office, so I was trying to not disturb the others around me. But Pedro, are there any other questions that have come up?
Yes. So I guess for Ollie, there's a question about, can the projects be care home based, or do they need to be for older people living in the community?
No, could be absolutely fine if it's an intervention which is designed for care homes, or would be taking place in care homes or focus on care home residents. That would be eligible.
Okay. So now, just for our colleagues in social finance, the outcomes-based model sounds a bit like the best practice tariffs in the NHS service and care for refractory patients. This builds in a minimum guaranteed payment with a top-up for hitting certain care markers. Does your model work the same way, or are the providers operating at a financial risk if they don't hit sufficient positive outcomes?
I can answer that if you want, Fleur. So to be honest, it depends on the nature of the investment and the partnership. So there's not a kind of one size fits all approach. If the investment is repayable, it does tend to be repayable if the outcomes are met, but the social investor takes on that risk for the first few years. So the social investor is essentially bridging the gap, taking the risk for the provider in terms of, we know things take a while, maybe mobilization doesn't go to plan, maybe there are other kind of bumps in the road, and also takes the risk for the statutory organization that often can't take that risk without the evidence that outcomes are being achieved. So that's what tends to happen. And I know we've been speaking to Sue about how this funding could be used in quite an imaginative way. I hope that answers the question. But yes, it's not a one size fits all, but we definitely, we basically work in partnership with all of the system stakeholders. So what we're trying to do is align incentives and minimize risk so everyone can take the leap of faith. We're trying to absolutely avoid kind of winners and losers, and certainly not put undue risk onto community or voluntary sector providers, or indeed NHS provider organisations. So we know how tough things are.
And next question. Yes, I guess it's more guidelines focus, so pass to you. Can the NHS Health Board be the lead?
That's a good question. Yeah, I think an NHS Health Board would count as an eligible research organisation. So might be worth just putting that in an email directly to us, just that we can be 100% sure. But off the top of my head, I think an health board would count as an eligible research organisation. So it could be a lead institute.
And I guess a bit of clarification regarding the involvement of PhD students or fellows in the grants.
So, I mean, there's no sort of total one size fits all here. Broadly, there might be a case to be made for example, a student being involved in specific aspects of the proposed work. I think the key message is that we don't want these very large, complex grants to be carried out as a PhD studentship or a cohort of PhD studentships or a postdoctoral fellowship, just because we're aware that can add sort of additional layers of complexity onto what is already probably going to be complex programs of work. So, you know, if there are specific cases where you might want to involve a student or a fellow in specific aspects of the work, then we could consider that, but these aren't designed to be carried out as a studentship or as a postdoc fellowship, for example. Hopefully that sort of clarifies that a little bit.
I guess maybe for Sue, can you give a bit more clarity regarding the level, extent, of evidence required for a proposal to be considered?
Oh, goodness. Well, I would suggest for a clinical intervention, as we said, that would be a peer-reviewed publication. If, for example, probably a live example is better. If you are a community organisation and you've had to evaluate your programme using a social value model, for example. So a model that, again, has been tried and tested. It's something that you have had a third party, a trusted third party evaluate for you, then yes, we would look at that. What I would say is, because that tends to be, that doesn't tend to be published, we would need to see that. And that's why Sanjay mentioned, Ollie mentioned, that we'd need to sort of have sight of that, or at least, be pointed to that in the expression of interest sessions. So yeah, it's basically about having a trusted third party, a respected third party, having evaluated your work. For some interventions, as I say, clinical ones, it's more likely to be peer reviewed. In a social care setting, there are a range of models out there. So you point us to that and tell us why you think this is robust.
And something actually I think that was really helpful. Just to add on, the one thing I think we wouldn't accept is sort of, if the only evidence is kind of a feasibility trial, which is just showing that recruitment is feasible and the intervention is acceptable, that alone is not going to be enough. We need to see evidence of sort of outcomes that are relevant in the context that you're looking at, if that makes sense.
Yeah. So one more other question. What is the definition of older? Over 50, over 65, no age number. The focus is on supporting adults to age well.
So I think I can take that. Yeah, so I guess in a nutshell, this is sort of the definition of older people or older adults. So we don't have a strict definition. Obviously, people like the World Health Organization, other organizations tend to use kind of 60 plus, 65 plus, and that's, I think, typically what we would expect as a definition for older people. We're aware that there are some populations where a case can be made that older is slightly younger than that. It's a funny sentence, but people with, let's give an example again, like Sue said, a live example is good. So people with Down syndrome, an older person with Down syndrome tends to be classed as maybe in their 50s rather than in their 60s, because of the sort of general life expectancy for that population. So there might be cases where you can make a rationale for older people being younger than the general 60, 65 plus. But that would be kind of the standard definition, I suppose.
I guess maybe for Sue, if we have a well-evaluated intervention, but from our PPI work, there is a further aspect of healthy lifestyle that they would like us to consider, resulting in a minor modification of the existing intervention, would this still be eligible for funding?
I would say so, absolutely. I said, with all of these things, make the case to us. And I would say that if that's come up from, people who are going to experience this, then absolutely. So yeah, make the case. And I think, well, if you've got PPIE evidence, then that sounds like it could make a pretty robust case to me.
And is there an expectation that the work will be UK-wide, or is there scope for developed nations to be the core focus?
No, it could absolutely be to the developed nations. As I said in my introduction, it could be local, it could be regional, it could be national. We're very aware, and certainly adopters don't have influence outside certain areas. So, that what we're looking for is practical, scalable adoption. So, define define local, regional, or national. And yeah, absolutely, it could be a devolved nations focus as well.
I guess it goes back to Fleur's point about what is meant by scale. And, you know, we're looking for interventions that can be implemented and evaluated at greater scale, but what counts as greater scale will differ for each proposal. So there's no set expectation as to how wide this implementation is for each individual proposal.
I guess this maybe for you, Ollie. Could you please expand on what kind of technological interventions might be? Could software to improve a service be considered?
Software to convert. I would say, I think you'd have to make a strong case. So like I said, we're not looking for standalone pieces of technology. So we're not looking for sort of the evaluation of a standalone piece of technology. We're looking really for wider services or programs that are being delivered to support older people's independence. So firstly, you'd have to make the case that can directly support older adults' independence. And I think what we're looking for is sort of the implementation and the evaluation of the wider service rather than simply evaluating a standalone piece of software.
So yeah, I think that's absolutely right. I think if it's a piece of software that's going to improve business efficiency or something, then that's a bit, yeah, you can obviously see how that could be made to say that people will experience more efficient service. But I think it's a little bit too arm's length for what we're looking for. You know, we need to be improving the lives of actual people directly. So yeah.
And yeah. Does the evidence need to come from the same team? Meaning, do we need to be building on our own work, or is it acceptable to build on other researchers' proved evidence for the intervention?
I don't think the evidence has to have come from your own work, but I would expect in most cases at least some of the people involved in the current proposal would have been involved in the sort of earlier development and evaluation of the intervention. Obviously, just as a general point about good research ethics, sort of, we don't want people taking someone else's intervention and doing it. So yeah, it wouldn't be a strict no, but I would expect that there would be some continuity there in most cases, probably.
And does it have to be a novel intervention, or can it be more about breaking down barriers to adoption of well-recognized interventions, for example, Mediterranean diet, exercise, etc.?
I think we're probably not looking for novel interventions because they already has to have evidence, so it's not really novel. So yeah, I mean, I think obviously we get lots of, that's a good case in question is exercise. We get we funded lots of work on exercise, actually really looking at how that gets adopted is absolutely bang on what we're looking for. But yeah, I think it'd be more difficult to make the case for a novel intervention, but it as I say, it depends what you mean by novel. If it is something that's already something new that's been piloted and tested already and you're looking to scale it up, then yes, that's what we're looking for. But to reiterate, we're not looking to seed a lot of new interventions.
And just can I add, because I realise language is such an important thing, and we spoke quite a lot about innovation, and really I suppose what we're here to support is making change happen, but fully recognizing what Sue said. Actually, for an outcomes-based approach, you have to have a level of understanding and rigor in terms of like what the benefit is going to be, what the outcomes are going to be. So it's really not about the kind of like new ideas side of things. But I realized that my own language might have been a bit confusing. So I just thought I'd use that opportunity to clarify.
No, it's a really important point, and one I was going to make, Katie, was about language. That's been the toughest part of actually defining this, because we want to be really flexible. There are lots and lots of different things that might be entirely eligible for this. So I think we're trying to be as clear as possible in what is not being funded. But the other good word that you pointed out there, Katie, was innovation. One of the things that I said at the outset was we are trying to do our best to bridge one of those well-defined valleys of death that everybody's saying you can't get funding for. So it's that sort of bit between, you know, you prove that something works in a small population, you've got that piece of evidence. Now let's look at scaling it up. But in itself, you know that there's a risk, you know, there are some risks in doing that. And that's the piece that we're looking at here. We're looking at the implementation bit of it, the implementation science as well, which we think is really important. So it's that bit of the innovation chain we're looking at.
I guess maybe it's a general. If a community-based intervention is already implemented to some extent, but there is limited evidence base around financial sustainability and health economic outcomes, would investigations exploring this issue be eligible?
Be eligible, yeah. Yes, I think so. I think we've said in the guidelines that you know, it might be that you have an intervention that has already been adopted to some extent, has already been evaluated to some extent, but you want to gather more evidence on the financial sustainability to help facilitate the sort of longer term adoption. And that would be eligible. So I guess the key thing would be making the case that the evidence you're looking to collect is going to help facilitate the longer term adoption and is of relevance to the adopter or the adopters that you are working with.
So a couple of things to follow up on there. Absolutely. You might have, and I mentioned this, a social return on investment that you've done a piece of work on that, and you can evidence that. That would be great. And that could then be a way that you can identify and adopt a partner who can work with you to test out a new financial model, and to actually do that piece of work. So you can go along and say, look, we've got the chance to get our hands on some funding to do this. Come and work with us on it. So that could be a way that you use this.
I think it's a similar question to before, but related to PPIE and the scale up. What are the, if we have already an intervention, but for scale up, we need modifications through PPIE or some other modifications, would this be accepted?
If there is, sorry, Ollie, go on.
No, go for it.
Well, I think I was going to actually say that on these case-by-case bases, where there's these little questions around patient care and public involvement, or the eligibility things, specific topics and issues, I think it might make sense to email us, and then we can assess that so that we can almost help you, guide you towards submitting an expression of interest. But Sue, I can also let you in. Sorry, that's one of the general questions.
No, I think it's a good call. But as we said before, if in the original kind of piece of work evidencing it, there were some modifications that were recommended, I think that would be almost expected, to as you move into that next step towards implementation. So yeah, but as Sanjay said, if there are specifics, we can always take a look at those.
I don't know if there is any more. There is a question that relates to, I believe, more to the next part of the webinar. So I don't know if there is any more questions.
Okay, well, if there's no more questions.
Sorry, I've just spotted one actually from Nahid.
Yeah.
Is a call necessary before submission of the expression of interest? No, it's not necessary. If there are points of small points of clarification that will enable you to put your expression of interest together, you know, you can email us about that. But no, it's not a requirement. The expression of interest call is a requirement.
Yeah.
If that's part one of your application.
Yeah, but just if you have small points of, you know, things you want clarified, yeah, would suggest you deal with those via email separately rather than booking out a slot for small points of clarification, because there are relatively limited numbers of actual expression of interest slots.
I guess the question that might relate to the next step of the webinar. My area aims to bridge the gap between staff well-being and person-centered care. I'm implementing a number of workshops for care home staff to inspire human flourishing and enhance person-centered cultures. My main question is, how can I develop these workshops to an ongoing program of work, and who can I collaborate with to make this a wider project? And I think this relates to our next part of the webinar, Sanjay.
Yeah, so as I mentioned, and I will be introducing a networking session at the end of this webinar if people would like to stay on the call. Yeah, and the chat is so amazing. I'm looking at all the intros, and we are definitely going to be sharing this. So rest assured, this gold mine of information that's popping up in the chat, we will be sharing it.
Great.
There's another question. Sorry, are educational awareness programs that aim to teach older about managing their wealth and independence, including safe use of IT tools, eligible for this funding? Again,
I guess this goes back to Sanjay's point about sort of specific projects that you have in mind. I can certainly see a case in which that could fit. Obviously, if these are programs that are being delivered directly to older people, then it could have a direct impact on their independence. But if you want some clarity around that, then I would suggest email us at the grants app email inbox, and we can sort of pick that up and look into that a bit more for you.
And I guess I'll just add that the guidelines are very comprehensive. We've obviously attempted to flesh them out in the webinar here as well. So please do read them before you contact us, because many of these questions will hopefully be already answered in the guidelines. And so we're a small team, answering questions that have already been answered in the guidelines isn't necessarily something that is the best use of support that we can give. So do rewatch the recording, which we will be sharing of the webinar, read the guidelines, and only if you don't feel that it has been answered, please do approach us and explain why you feel it hasn't been answered, because that will also help us improve how we provide guidelines in the future as well.
Okay. Oh, I think we might be sort of there, Sanjay, in terms of.
Yeah, okay, great. Well, I just wanted to say thank you to everyone in the Dunhill team and for Katie and Fleur for presenting. Thank you to everyone who has attended for their time and their questions and the amazing sharing of information. So as I said, the further questions, please do look at the guidelines, do rewatch the webinar, do look at the slides. However, if you do have further questions, we are always happy to help. So as I said, the recording, the slides, and the chat will be available on our website and sent to registered attendees. We do have some time for structured networking up until, I think, 12:30. So this part won't be recorded, and so for those who have asked, who wish to stay, please do stay. For everyone else, I guess this is for us to say thank you very much for your time, and yeah, looking forward to hearing some chat in person. So we'll stop the recording.